Hello, Swapnesh.
Yes, sir.
Let's start the meeting. I think it's 8 o'clock. No?
Yes. Yes.
So I think you can start. Then what do you want? Or should I start?
Yes, sir. Please start.
Yeah, good evening, everybody. I welcome you all for the second session of our PG teaching and quiz. Today is the second session. First was done on 8th of December. And today NIO is going to be there. In the first session, it was JJ Hospital. So NIO is a super specialty eye hospital in Pune, and they also have a Retina fellowship. And we are fortunate to have Dr. Aditya Kelkar, Dr. Zai Kelkar, and Dr. Nikhil Lakshetwar as experts for today's session on Retina for postgraduates as well as practicing ophthalmologists. We will have one long case, one short case, and two talks. So let's start the session. This will be followed by quiz. There will be 5 questions. And at the end of the quiz, we will declare the results of last time quiz. There were 102 participants, of which 55 actually attempted all 5 questions, and only 6 were able to give all correct answers. So that result will be declared at the end of today's session. So Swapnesh, let's start the lesson.
Yes, sir. I request Dr. Aditya Kelkar sir to say a few words, and then request Dr. Harsh to share his screen.
So I would like to thank the Maharashtra Ophthalmic Society Chairman, Secretary, and the Chairman Scientific Committee as well for giving us this opportunity to share some cases and a couple of talks in front of you for the postgraduates. I also take this opportunity to wish our Chairman Scientific Committee a very happy birthday. And with that, I think we should start our session today.
Yeah. Dr. Harsh, you can start sharing your screen.
Yes, sir.
And a happy birthday to Dr. Vardhaman.
Thank you. Thank you very much, Swapnesh and Aditya. Thank you.
Is my screen visible, sir?
Let's start. Yeah. Screen is visible and you are audible.
Yeah, thank you, sir. So today we are going to have a discussion on a management of an IOFB in a child. So a 9-year-old male child presented with left eye pain and redness of sudden onset with following a penetrating injury with an iron particle while playing. The examination showed a BCVA of 6/6 unaided in the right eye and a vision of 6/9 unaided in the left eye on Snellen chart. The right eye anterior segment examination was within normal limits. The left eye extraocular motility was full and free in all cases. Lid and lid margins were normal and there was no foreign particle noted in the fornexus. Subconjunctival hemorrhage with the entry wound on the nasal side was noted. The cornea was clear, AC was well formed, pupil was reacting to light, and the lens was clear. So seeing the anterior segment examination, we suspected a foreign particle IOFB in the posterior segment. So on dilated fundus examination of the left eye, the posterior pole was seen to be within normal limits. We could see a foreign particle of approximate size of 4:5 mm located in the inferior vitreous. Adjoining area of retina showed edema due to retinitis along with retinal exudates. The right eye fundus photo was within normal limits. Workup including fundus photo B scan was done. The CT scan orbit of the patient confirmed the intraocular position of the probable metallic foreign body. Management with vitrectomy with IOFB removal was planned for the patient. The entry wound exploration showed a self-sealed scleral wound found superinasally. So we proceeded with 25 gauge ports and pars plana vitrectomy. The PFCL was then, IOFB was then localized in the inferior quadrant. PFCL was injected over the posterior pole and the vitrectomy was done around the IOFB to free it from its vitreous attachments or adhesions. A sclerotomy was enlarged using a MVR blade, which was further enlarged with the help of a keratome. The metallic IOFB was then held with the help of a magnet and then rotated posteriorly to avoid injury to the crystalline lens, and then was successfully removed from the sclerotomy. We can see the successful removal of the IOFB. Vitrectomy was proceeded and endolaser was done to the adjoining retinitis area around the IOFB, and the sclerotomy was sutured then with the 8-0 vicryl. On follow-up, we can see the fundus photo of post-op day 1, and after 2 months, the posterior pole is still within normal limits with the laser scars in the inferior quadrant and inactivity in the area of previous retinitis. At 2 months follow-up, the patient's unaided visual acuity is 6/6 parts. There were no signs of retinal detachment or vitreous hemorrhage on follow-up. There was no incident of a decrease in vision or any adverse reaction noted throughout the follow-up period. So the take-home message from this case is that the documentation of the IOFB should be done in every case. And the IOFB should be localized on CT scan, whether it is an intraocular IOFB or an extraocular IOFB. Removal of the IOFB and restoring the ocular anatomy should be done at the earliest and is of key significance. Be wary for the signs of endophthalmitis and toxicity from a metallic IOFB, and if seen, have to be treated immediately. Thank you.
So
Yeah, I
think,
request Dr. Aditya sir and Dr. Zai madam to proceed with the questions for the long case.
So this is more like a mock exam. So for the benefit of the students, I would like to say that most of the times, the most frequently asked question when you have a patient such as this is about siderosis bulbi. So let's ask Dr. Harsh about what he knows about siderosis bulbi and what is the earliest sign of siderosis bulbi.
So siderosis bulbi will be the accumulation of iron in the intraocular tissue. So starting from the anterior to posterior, we would see rusty depositions of the iron particle in the cornea. Along with that, we can see iris deposited on the iris, which causes a parasympathetic neuropathy, leading to a dilated iris. And because it affects the sphincter pupillae as well as the dilator pupillar muscles, along with that, it can also get deposited over the anterior capsular anterior capsule of the lens, which can further progress to development of cataract. Further going behind, it can also lead to retinal degeneration, which can be pigmentary associated with arterial attenuation. In the chronic or the long run, we should be wary of glaucoma because these iron particles can get trapped in the trabecular meshwork, causing an inflammation and obstructing the outflow of the aqueous. So these all things from starting to end and even in the long runs have to be looked for, and if noted or detected has to be treated immediately. One of the classical signs could be seen as heterochromia, in which the brownish coloration of the eye can distinct it from the non-affected eye.
That's good, Dr. Harsh. So how much time we have for the next questions, or we have to move to the next case now? Dr. Swapnish?
can I ask one more question? One
Dr.
more
Nikhil,
question.
do you have anything to ask?
Sorry, I didn't hear it.
Dr. Nikhil, do you have anything to ask? I'm not able to hear you.
Unmute, I think.
We can take the long case up to 8:15. We have 4 more minutes to go.
All right.
You can hear me now?
Yes, sir.
Yes.
Yeah. What all structures can a foreign body get embedded in the eye?
So the anterior examination is basically done to see the structures which are affected to find the trajectory of the IOFB. So considering that if it's a very small particle, the IOFB might just get lodged in the angle. So doing a gonioscopy would be of key importance. It might get embedded in the iris, or it can create a iris tear and pass through it, or it can tear the lens, or it can pass through the zonules as well, and then go posteriorly to get embedded in the retina or subretina or even in the subscleral space. So these are the potential sites of it getting lodged or embedded depending on the trajectory which the IOFB has taken. So the inclusion of these structures will depend on what trajectory was followed by the IOFB.
Okay. Okay. Thanks.
Dr. Harsh, supposing there are two foreign bodies, one, as you said, is intraocular, and the CT scan has shown another foreign body which is in the orbit, say behind the globe. Then how would you manage such a situation? What would be your steps of management?
First, I would like to first identify the nature of these foreign bodies, whether they are metallic or non-metallic. There can be an external approach as well as an internal approach. If the two foreign bodies are too nearby, we can try and attempt for a intraocular approach for the intraocular foreign body. But if it's a metallic one, which is the outside the orbit, and it is causing signs and symptoms like extraocular muscle restriction or movement restriction, we can just go extraocularly with the help of a magnet and try to find out whether it is attached or embedded at the sclera. If yes, then we'll have to first free the ion, the foreign particle, or if it's an ion or anything, from the adhesions at the sclera of the soft tissue. And then external approach is used to remove the IOFB, which is extraocularly. Intraocularly, if it's embedded subretinal or retinal, or if it's in the vitreous cavity, we have to go for an intraocular approach with it. The both approach might lead to ocular damage and tissue damage, but considering the toxicity effect of this IOFB causing may lead to vesicle bulbi, we should always try to remove them as soon as possible over the tissue damage which is created by the approach.
So the question here is that whether you can leave a foreign body which is outside the eye.
Yeah, if it's not causing any issue with the extraocular muscle movement and patient is asymptomatic and it's an inert foreign body, then we can leave the extraocular one outside and the intraocular one has to be removed.
That's correct. Thank you. That's good. So I think we can move on to the next case now.
Yeah, I request Dr. Apurva Jadhav to please share the case, and he would be talking on a short case regarding optic disc pit.
Good evening, everyone. Am I audible?
Yeah, you're audible.
So good evening, everyone. I'm going to present a case on human amniotic membrane graft for the management of recurrent optic disc pit associated maculopathy in a pediatric case. So presenting a case, a 13-year-old girl presented with diminution of vision in her left eye since 2 weeks, which was not associated with any kind of history of trauma. The patient had given us history of she was successfully operated 9 months back for optic disc pit associated maculopathy with 25 gauge pars plana vitrectomy with ILM peeling, with inverted ILM flap with SF6 gas tamponade and juxtapapillary endolasum. So in presentation, patient was giving vision of right eye 6.9 and left eye 6.36. On fundus examination, it showed us a recurrence of the serous detachment of the macula secondary to optic disc pit. Whereas on the OCT, the optic disc pit associated large localized bullous macular detachment with retinoschisis was noted. The next management which we did was a cryo-preserved wet human amniotic membrane graft of size 3 mm was pre-cut using a 3 mm trephine, and the graft was stained using brilliant blue stain. Under general anesthesia and under all aseptic precautions, 325 gauge sclerotomy ports were made. Thereafter, the stained human amniotic membrane graft was introduced into the eye with the help of intravitreal forceps and stuffed into the optic disc pit. The proper positioning of the human AMG was confirmed by intraoperative OCT. Showing a small video as how we have done the surgery. A human amniotic graft was stained with brilliant blue, and then it was stuffed into the optic disc pit. And then with the help of the intraoperative OCT, we could localize the amniotic membrane graft. And we could see the proper positioning of the human amniotic graft. The follow-up photos, the follow-up post-operative OCT shows us the complete resolution of the maculopathy within 48 hours after the surgery. 1 week post-op fundus photo showing complete resolution of the bullous macular detachment. Her best corrected visual acuity improved to 618 after 1 week. After 6 months, the post-operative OCT showing no recurrence of optic disc pit maculopathy after 6 months. The below picture shows us, OCT shows us no recurrence of any optic disc pit associated maculopathy even after 1 year. Now the patient is maintaining vision of 618. To conclude, I would like to say optic disc pit maculopathy is a rare presentation in children. Only a few pediatric cases successfully managed have been reported in the literature. Rizzo et al. Recently, he described an innovative surgical technique for the management of optic disc pit maculopathy with 1.5 mm graft in treatment naive adult patients. But in this case, we have used a larger 3 mm graft due to the larger size of the ODP. This larger graft got snugly fit into the pit, obviating the need for additional perfluorocarbon liquid or gas tamponade for stabilization of the graft. The advantages of human AMG is because of the malleable and the pliable nature of the human AMG, it snugly fits into the optic nerve head pit better than rigid scleral tissue such as ILM. Harvesting a human amniotic graft instead of a scleral flap drastically reduces surgical time and also improves patient comfort. The literature states that the average time taken for the resolution of ODP maculopathy ranges from 4 to 12 months. We observe complete resolution within 48 hours. This may be attributed to the snug fit of the larger graft and to the already victimized status of the eye. Thank you.
Thank you. That was a unique case. We have time till 8:30, so I think I request examiners to cover this topic as well as few questions on central visual loss.
Yes,
Thank you so much.
Very interesting case, Dr. Apurva, and this case is very dear to us since this case also won the Best of the Show award at the American Retina Society last year. And this is what is very unique about this patient is that the recurrent optic pit was managed with a larger size of the graft. At the same time, we did not have to use any gas or any additional tamponading agent. We did not have to use any laser. And just by the snug fit of this large size graft, we were able to resolve the macular pathology within 48 hours. So asking you a question which is related to pathogenesis of this optic disc pit. So what are the theories about how this optic pit maculopathy evolves, or how does it form? Can you enlighten us on
it is said to be that there is connection between the vitreous cavity and the optic disc pit, which causes the which causes the submacular detachment, serous detachment. One of the theories is this. And the second one is there is a connection between CSF fluid to the optic disc pit, and then via through that, it has been affected for the serous macular detachment. So these two other theories which said to be the cause for serous macular detachment.
The reason why internal limiting membrane peeling is done in these cases is to relieve the tangential traction on the macular area, because that may be one of the reasons why the optic disc pit is allowing the fluid to enter into the submacular space. So another primary treatment for optic disc maculopathy is to have two-staged internal limiting membrane flap, the one which covers the macular schisis foveal area, which is thinned out in these patients, and the other flap should cover the optic disc pit, which then stops the communication of the vitreous cavity and the submacular space. So that's the treatment that is done primarily. And if it fails, then obviously there are other techniques apart from amniotic membrane graft. Do you know of any other alternative techniques?
Yes, we can use platelet, autologous platelet for this case also. Then scleral tissue, autologous scleral tissue can also be used.
Anything else?
And we can do laser around the optic disc pit, where there is, if there is any communication between the optic disc pit and the submacular macular area, then we can do laser for that.
That's correct. So the laser is done around the area of optic pit in the papillomacular bundle itself. But at the same time, along with internal limiting membrane graft or amniotic membrane graft, and as you said, the platelet concentrate, we can also use tissue glue, which can also be used as an agent for blocking the optic pit. And in cases where you use a smaller amniotic membrane graft, an adjuvant of the tissue glue can also be used to plug that area so that the tissue doesn't get dislodged. But in our case, obviously, it was a larger graft and we were very sure that it's getting snugly fit into the optic pit. We did not have to use any such adjuvants. All right, Dr. Zai has a question.
Nice presentation, Dr. Apurva. Before moving on, let me take you back a little bit. It's a child, 13-year-old, you said. Then children usually will not complain of any visual disturbances. Very rarely they'll tell about macropsia. So how do you diagnose a macular pit, the optic pit in a child?
Actually, this is the optic disc pits are usually incidental findings. And because there was involvement of the macular area, that's the reason the child could say that she has a blurring of vision or diminution of vision because of involvement of the macular area.
What did you see clinically in the macula?
Ma'am, central there was edematous area.
And then what are the differential diagnoses that you will consider in a child with optic disc?
So if it is considering only the optic disc pit, we can DDs are, ma'am, it can be optic morning glory syndrome or any kind of glaucomatous optic disc changes. And if we consider the macular area region, then it is said to be idiopathic CSR is differential diagnosis for it.
In fact, even the retinoschisis, X-linked retinoschisis can also be a differential diagnosis for this type of optic disc maculopathy. You said rightly, in adults, if you have an optic pit, it can be an acquired optic pit as seen in some of the glaucoma patients. They have an acquired optic pit. So that's correct.
And how did you investigate this case?
So we further did OCT for this patient. Then OCT confirmed the retinoschisis, the separation of retinal layers, and the fundus photo also showed us the optic disc pit, the grayish or the grayish oval area in the optic nerve head.
So when you describe any lesions of this kind, you should always tell the location where the pit is located, usually infero-temporal or wherever this pit was, and the color, how did it differ from the other eye, or was it present in the other eye? So you should, how were the retinal vessels? So make it a habit to describe everything starting from the pit, then following the blood vessels, going to the macula and the periphery. So you won't miss any finding.
And of course, another important thing is these patients also require visual rehabilitation after the surgery. So without Dr. Zai prompting you, I must tell you that this patient also should be considered for amblyopia therapy. So I think that's about this patient and a very interesting presentation once again. Thank you. Moving on to the next talk by Dr. Arvind Camus, and he comes to us from Manila, Philippines, and he's doing his retina fellowship with us. And he'll be talking about OCT biomarkers. Often we see when we look at the OCT scans, we are mainly interested in finding out whether there's subretinal fluid or intraretinal fluid and what is the central macular thickness. But beyond these three things, there are some other biomarkers which also tell us about the prognosis of the patient, and Dr. Arvind is going to highlight a few of such biomarkers for us. Dr. Arvind, please.
Hello, good evening, doctors. I'm Dr. Erwin Camus, and I will be talking about OCT biomarkers. So a biomarker's main application is for predicting and monitoring of clinical response to treatment. The following are normal OCT images of the macula. We can appreciate the layers from the neurosensory retina down to the choroid sclera junction. I'll be showing images of some of these biomarkers that we can look for given patients wherein we would request for an OCT, like macular edemas, degenerations, and choroidal neovascularizations. Disorganization of the inner retinal layers. Upper images show segmentation of the inner retinal layers with the white lines demarcating the boundaries between IPL, INL, and INL, OPL. Lower images exhibits drill, hence the explanation of poor vision in a patient with diabetic macular edema. Another OCT image of a patient showing DRIL. We can see the discontinuity of the retinal layers on this part, cystic spaces. ELM and ellipsoid zone disruption. Image A shows large cystic spaces and exudates. EZ and ELM were intact with BCVA of 6/9. Image B shows that the macular OCT of the same patient 5 years later, extensive ELM and EZ disruption developed, which involved the fovea. BCVA then dropped to 6/19. DME associated with vitreomacular interface abnormalities. This image shows us a dense epiretinal membrane overlying the retinal surface with elevated foveal contour and significant intraretinal cystic spaces. Central subfield thickness. This image shows CRVO-associated CME, subfoveal fluid, and disruption of the ellipsoid zone. Note the highly elevated central subfield thickness. This OCT demonstrates fibrovascular pigment epithelial detachment centrally with adjacent and overlying subretinal fluid, resulting in increased CST in a patient with neovascular AMD. Pachychoroid. In this patient with central serous chorioretinopathy, his OCT demonstrated markedly thickened choroid, as you can see in this area with the white arrowheads. Cuticular drusen. This image shows 3 types of cuticular drusen. The green ones exhibit shallow elevations. Red arrowhead appears like a sawtooth, and yellow arrowhead exhibits a mound-shaped elevation. Reticular drusen. Reticular drusen has 3 stages. Stage 1 has diffuse hyperreflective material between the RPE and ellipsoid layer without elevation, as you can see in this pink arrowhead. And this red arrowhead, stage 2, indicates increased accumulation of material and distortion of the ellipsoid layer. And stage 3, yellow arrowheads, manifest punctures through the ellipsoid layer. Calcified soft drusen. White arrowheads points us to calcified drusen showing hyperreflective sheet with a hyperreflective content and hyperreflective dots. Subclinical neovascular membranes. Superiorly, NFAS OCT shows subretinal neovascular complexes in the outer retina and choriocapillaries, and inferiorly, OCT-B demonstrates subclinical neovascular membrane. Of note is the absence of intraretinal or subretinal fluid. Hyperreflective foci. This picture points HRFs in the inner and outer retina. Acquired vitelliform lesion. This scan detected accumulation of material between the ellipsoid layer and the RPE, which is located above a drusen. Drusenoid PED. This OCT-B scan, we can appreciate drusenoid PED. Macular neovascularization type 1. This figure shows type 1 neovascularization, and OCTA detected a branch vascular network ending in an aneurysm formation located between the RPE and the Brooks membrane. Type 2 neovascular complex is located between the RPE and the neurosensory retina, shown here. And in type 3 neovascularization, lesions are located in the superficial and deep segments of the retina. On the left is before treatment with anti-VEGF, and on the right, after the first injection, which tells us that this type of neovascularization tends to respond well with anti-VEGF treatment. RPE and outer retina atrophy. Now, in this slide, we can see complete RPE and outer retina atrophy. This scan demonstrates an area with choroidal hypertransmission due to absence of RPE and overlying outer retinal thinning. Now on to incomplete RORA, OCT displays a heterogeneous choroidal transmission. You can also see subsidence of the INL and OPL. So there's a dip in this area. For complete outer retina atrophy, this scan demonstrated thinning of the outer retina with loss of visibility of the interdigitation zone. Next is complete ORA. There is thinning of the outer retina where intermittent areas of interdigitation zone can still be identified. Outer retinal tubulation. Demonstrated in this scan is an outer retinal tubulation in a case of neovascular AMD, this white arrowhead. Bacillary layer detachment. In a patient in an acute stage of VKH disease, we can see the bacillary layer detachment below the ELM. So this is the photoreceptor layer, then separated into two. Photoreceptor layer attached in between. Subretinal hyperreflective material. This OCT demonstrates HRAM that is indistinguishable from the RPE. So it's inside, internal to the RPE. Paracentral acute middle maculopathy. It is seen in the OCT as a band-like hyperreflective lesions at the level of the INL. This part. Pearl necklace sign. This scan demonstrates pearl necklace sign pre-treatment and 3 months post-treatment, showing hard exudates. It is told that the pearl necklace sign is a precursor of hard drusen's, and it would affect vision if it's located underneath the fovea. I think that's last slide. Thank you for your attention.
Thank you, Dr. Arvind. So that was quite a good presentation on OCT biomarkers. So the outer retinal tubulations, and so what is the significance of the outer retinal tubulations as you described on the OCT?
So photoreceptor rearrangement after the injury. Example would be retinal degenerative diseases, circular or tubular arrangement. Eyes with ORTs have worse visual acuity, central macular thickness, and retinal sensitivity.
Did you discuss about drill in the presentation?
Yes, doctor.
So we can just go back to that picture and explain to the audience as to what exactly the drill is.
So again, drill.
Significance again.
Disruption of the demarcating interface lines between the ganglion cell layer, plexiform complex, inner nuclear layer, outer plexiform layer, and outer nuclear layer. So you can see here alternating layers of the retina, and eyes with drill have a worse baseline VA despite anti-VEGF treatment. As you can see here, you cannot distinguish layers of the retina. Hence, they have poor visual outcomes.
Also, another biomarker was the progressive acute middle maculopathy, which is seen in patients who have vein occlusions, and it indicates an acute insult or acute ischemia of the retina. So
Yes,
just
doctor.
point out where this PAMM is located.
So these are localized retinal capillary ischemia at the level of the intermediate plexus. So in between, middle retina layer.
So these are some of the important biomarkers that one should look for, apart from looking at the central macular thickness and also the intraretinal cyst as well as submacular fluid. Going to the next presentation is by Dr. Sukanya, and she's doing her retina fellowship, DNB retina fellowship, and she's into her final leg of her retina program. I would request her to brief us about the vascular occlusions and some of the principles of management of vascular occlusion. Dr. Sukanya, please.
I'm audible to everyone.
Yes,
I'm
very
audible
much.
to
Yes,
You
go ahead.
are audible.
Okay. So good evening, everyone. I'm Dr. Sukanya from National Institute of Ophthalmology. Today, my topic of discussion is retinal vein occlusions. So this is the most common vascular disorder, the diabetic retinopathy. It can be in the form of central retinal vein, branch retinal vein occlusion, papillophlebitis. Predisposing factors are increasing age, systemic hypertension, diabetes mellitus, hyperlipidemia, and also there are some thromboembolic disorders, vasculitis, and of course raised intraocular pressure or glaucoma. Note that the retinal artery and vein both share a common adventitious sheath, and atherosclerotic change in the retinal artery, it gets thickened and it imparts a compression to the vein at the AV crossing. So there is resultant turbulent flow, endothelial damage, thrombosis, and finally occlusion. Central retinal veil occlusion occurs when this compression occurs at the level of lamina cribrosa. So it presents with unilateral sudden onset painless loss of vision. On fundus examination, we can see widespread dot blot hemorrhages and flame-shaped hemorrhages spreading all over the retina. There may be cortical spots, macular edema, optic disc edema. When it is spread along to the one half of the retina, we call it a hemicentral retinal vein occlusion. And all occlusion may show vascular sheathing and venous collaterals, which are nothing but an effort of the retina to establish perfusion from the non-perfused area to the non-perfused area. Central retinal vein occlusion can be of two variants, non-ischemic and ischemic. Ischemic is of more dangerous variety because it presents with a marked vision loss of less than 662 hand movement range. Afferent pupillary defect is present most of the times. There is extensive hemorrhages, cortical spots compared to non-ischemic variety, which presents a variable hemorrhage, variable extent of hemorrhage, and we call it a blood and thunder appearance. Macular edema also is more severe. On fluorescein angiography, you can see more than 10 disc area of capillary non-perfusion area. Majority of the patient will develop NVI or NVA, and there will be a depressed B wave amplitude on ERG. So the left picture demonstrates a non-ischemic CRVO, and the right one a typical ischemic CRVO. The complications are in the form of anterior segment neovascularization of the iris, angle, and resultant glaucoma, NVE, and macular edema ischemia may be there, all of which can cause vision loss along with vitreous hemorrhage. So the role of fundus fluorescent angiography in CRVO is mostly to describe the area of capillary non-perfusion and to differentiate between macular edema and ischemia, which determines the later treatment protocol, and to find out the neovascularization area. It is done mostly after 4 weeks and it shows delayed retinal vascular filling and increased AV transit time. Also, OCT is an integral part of the workup for CRVO patients. It measures macular edema pre and post injections. Now coming on to branch retinal vein occlusion. Here the occlusion of the vein occurs at the level of a branch retinal vein, which in a site of AV crossing. The extent of the hemorrhages are mostly segmental or a quadrantic distribution. The superior temporal area is found to be the most common. There are dilated tortuous vein, cold occlusion may show vascular sheathing and collaterals. The complications are in the form of NVD, NVE, vitreous hemorrhage. The neovessels can fibrose and they can impart tractional pull to the retina to cause tractional retinal detachment. There may be macular edema and ischemia. All of these can cause severe, moderate to severe vision loss. Fluorescein angiography again can describe the capillary non-perfusion area, which is mostly in the range of 5 disc area. Then it differentiates between macular ischemia and edema. And OCT is again needed for measuring the macular edema pre and post therapy. Papilloflebitis is basically the CRVO of young patients. There is inflammation of the central retinal vein and optic disc. Visual prognosis is often poor with chronic cystoid macular edema. So any RVO patients should undergo general investigations with complete CVS workup. The patients who are presenting at a young age or bilateral disease should undergo screening for thromboembolic risk factors like homocysteine levels, protein C, S, vitamin B12. Now the treatment algorithm for CRVO, apart from the baseline investigations like visual acuity, color fundus photograph, FFA, and OCT, we should always remember to do gonioscopy both in baseline and on follow-up visits.
In case of non-ischemic CRBO, if the OCT shows macular edema and the visual acuity is more than 612, we can observe the patient for spontaneous resolution. But if the vision is less than 624, we should start treatment with intravitreal anti-VEGF, monthly doses of injection for at least 3 months and then follow up. And if the vision is less than 660, we should always look for neovascular changes in the retina and anterior segment, as there are high chances. In ischemic CRVO, when there is anterior segment neovascularization, NVI and NVA present, but there is the angle is open, then we should go for urgent PRP with or without intravitreal anti-VEGF injections. If there is NVG and the angle is closed, urgent PRP should be done with tube shunt surgery. If there is no NVI or NVG, we can still do prophylactic PRP, provided FFA shows an area of more than 30 disc area of capillary non-perfusion. And for chronic macular edema, we can opt for Ozurdex implant, which needs retreatment after 4 to 6 months. But we should have to, we will have to monitor for raised IOP and progression of cataract. Now, the treatment algorithm for BRVO, in non-ischemic BRVO, if the visual acuity is more than 612, we can observe. If it is less than 612, with macular edema and hemorrhages are not masking the fovea, we should do an FFA or OCT angio wherever the facility is available. If there is macular ischemia, then we should observe for neovessels. If there is no macular ischemia, we can straight away go for an intravitreal anti-VEGF steroid. If the visual acuity is less than 612 with macular edema and the hemorrhage is obscuring the fovea, then intravitreal anti-VEGF should be started immediately. And FFA should be done every 3 months to look for macular ischemia. Chronic macular edema, even after injections, there is a modified grid laser photocoagulation as an option. And if the macular edema resolves and then recurs after treatment, we can restart treatment with anti-VEGF Ozurdex. In ischemic BRVO, there is presence of NB, and we usually do sectoral laser photocoagulation in those cases. And three monthly follow-up should be done for at least 2 years. Now, intravitreal anti-VEGFs are mostly used are ranibizumab 0.3, 0.5 mg. These ranibizumab has been shown to be of beneficial in CRBO and BRBO cases in CRUISE, BRAVO, RETIN, and Horizon treatment trials. Bevacizumab are used 1.25 milligram off label, both in India and abroad. Aflibercept 2 mg can be used. It has been shown to be beneficial, as good as ranibizumab or even better than ranibizumab in Copernicus, Galileo, and Vibrant trial. They have advantages of being used in glaucoma and phakic patients. They are safer. The disadvantage is high cost and monthly injections. Intravitreal steroids, on the other hand, are in the form of triamcinolone acetonide. And dexamethasone intravitreal implant is there in the form of Ozurdex. The advantages are they are suitable for patients with pre-existing thromboembolic disorders, in which ideally an intravitreal anti-VEGF injection like ranibizumab shouldn't be used. They continuously release the medication for 4 to 6 months. So monthly use of ranibizumab can be obviated. They are mostly beneficial for pseudophakic patients because they have the disadvantage of monitoring for glaucoma and cataract. So that's in a nutshell. Thank you all.
Thank you, Dr. Sukanya, for your excellent talk on vascular occlusions. So can you once again elaborate as to clinically how you will distinguish between ischemic central vein occlusion and non-ischemic CRVO? Maybe
Yes.
about, say 4 or 5 points that will help us.
Yes, so it is can I show the slide again?
Sure.
Yeah. So, excuse me. For non-ischemic CRVO, the vision loss is not as marked as ischemic CRVO. It is mostly in the range of 612 to 636, and but ischemic CRVO patients with marked vision loss less than 662 hand movement range. RAPD is often present in ischemic variant of CRVO. Also, the hemorrhages and cottonwool spots are more widespread in case of ischemic variant. There is macular edema, which is less severe in case of non-ischemic, and ischemic variety shows more severe extent of macular edema. Fluorescein angiography in non-ischemic variety shows less than 10 disc area of capillary non-perfusion. In ischemic variety, it is at least more than 10 disc area of non-perfusion. Anterior segment neovascularization in the form of NBI or NBA is mostly seen in ischemic variant. In majority of ischemic variant, there is a reduced B wave amplitude, which is not mostly seen in ischemic variant of CRVO.
That's great. So coming to another question regarding the management of these patients. So what would be your drug of choice? Suppose the patient is pseudophakic,
Yeah.
say 65 years old and non-glaucomatous patient. What would be your drug of choice for injection therapy?
A pseudophakic patient with non-glaucomatous, we can always use Ozurdex because it reduces the necessity for monthly injections and monthly follow-ups, because it has an advantage of for every 4 to 6 months. Yes.
But at the same time, you still need to follow these patients up after giving Ozurdex for.
Yeah, every monthly follow-up should be done, but the whole treatment cost gets reduced for if we see the cumulative cost of a ranibizumab for 3 to 6 months and Ozurdex for 6 months, the cumulative cost gets reduced for the patient.
That's correct. So, Dr. Nikhil, do you have any questions to ask for Dr. Sukanya?
As you said that we wait for fluorescein angiography for 3 months. So what is the reason? Why don't we do it earlier? Any specific reason why do we have to do it only after 2-3 months?
Because we actually look for neovascularization, and the extent of neovascularization occurs after 4 weeks only.
Not only that, the hemorrhages that you have on the superficial hemorrhages that you have.
Yes, they mask the capillary non-perfusion area which we are looking for.
So usually the hemorrhages will take 2-3 months for its resolution. So then only we can really differentiate between ischemic and non-ischemic. So that's why we call it as 90-day glaucoma also for this.
Yeah.
Usually we get glaucoma after 90 days or after 3 months. Only thing is, in this era of anti-VEGF, nowadays we are giving so many anti-VEGF. So nowadays glaucoma is coming at a later stage.
Yeah.
So it's not only 3 months, it can come even after 4, 5, 6 months after stopping the anti-VEGF treatment. So we have to still keep on looking for these patients. Almost 1 or 2 years, we have to have a good follow-up with. What are the red flag signs in RVOs? Are there any specific conditions where you have to look for the etiology?
Yes, when there is the young patient developing RVO in both eyes, then we'll have to look for some metabolic diseases like protein CS deficiency or thrombophilia.
Fine.
That's great. So coming to another, of course, now the surgical treatment for vein occlusion is almost obsolete, but one of the theories was that the scleral, the optic nerve creates something like a carpal tunnel syndrome for the central vein occlusion to get choked, and so there was a treatment called as sheath decompression
Yeah.
or optic nerve fenestration actually.
Fenestration or sheath.
The sheathotomy was done for the vein occlusion, branch vein occlusions. So of course, one of the treatments done about 20 years ago hasn't come into clinical practice after that, since the anti-VEGFs are doing a great job for us. All right, then I think that calls. Let's
So
call it.
now there is a quiz. There will be 5 questions
Correct.
of quiz. Sunil, are you there?
Yes, sir. I'm there, sir.
Yeah, so you can start quiz and the attendees can start answering.
Okay, you want me to straight away to put the quiz, or you want me to put the slides sir, first?
Yeah,
Somebody's going to put the slide, I believe.
Which slide?
The quiz slide, or should I just go straight away with the quiz?
Then go straight away with the quiz.
There is no PPT.
PPT already you have, no? PPT of quiz questions.
Okay, let me just get it, sir.
We will just, you can just tell that there will be 15 seconds and you will have to press.
Just allow me, just allow me 1 minute. I'll just put it up, sir.
We are short of time. So we will go with the quiz of 5 questions. Then we will declare results of last time quiz. Last time we had 102 participants and 55 of those participants attempted quiz and 6 people did all 5 correct. And we have fastest finger first also amongst that 6. And then we would like to thank those who helped us in last Retina 1. So we have prepared some certificates for them. And for today's participants, we will give certificates in the next PG teaching session, which will be there on 4th of January. And next month, the theme or the topic will be cornea. So on 4th of the January, we have cornea 1. And on 18th January, we will have cornea 2. And today, after this program, we have MOS and BOA Journal Club meeting. And we have Dr. Vaishal Kenia and Dr. Parul Deshpande. I would like to thank them for taking this. And we have an interesting case which will be discussed during Journal Club meeting. So I request everybody to keep logged for this Journal Club meeting as well. Sunil, are you ready with the quiz?
Yes, sir, I got it. I'm just putting it on the slideshow.
So,
one humble request to everybody who's willing to participate. Please do not type your answers in chat. It is going to be for 15 seconds. And there will be a pop-up on the Zoom screen. You will have the opportunity to answer the questions. There are going to be answers. Please select the right answers. Come what may, please do not write anything in the chat. You are losing your opportunity to participate, and you are also, influencing the answers in the chat. So just don't write anything in the chat. The pop-up will come on the screen. You will have ample time to respond. Come what may, do not write anything in the chat. So we are starting the quiz. I'm sharing the screen.
Do not answer in chat box.
So this is the first question.
This is the first question. A 63-year-old male walks in with complaints of sudden onset in his left eye. Visual acuity is 20/30 in that eye, and he's diabetic and hypertensive. Left eye fundus photo is shown. Visual field is given. And his other eye is normal. And cup disc ratio is 0.1. So diagnosis will be. Sunil?
So I'm putting the first question on the screen. It is going to be there for 15 seconds. Please choose your answer.
We have not shown the options, Sunil. Yeah.
The answer is the questions of this.
Yes. So now the time starts.
Five more seconds. Closing the quiz. The correct answer.
The correct answer is B, non-arteritic anterior ischemic optic neuropathy. So next question, Sunil. So here is a picture from 50-year-old man with AIDS He's not on ART and he presents with decreased vision and photopsia in his right eye. The most likely diagnosis would be. Sunil, next slide. You can show the.
Yes, sir.
Yeah. So now time starts now, right?
So we are starting the quiz.
Yeah.
The quiz is on the screen. Please answer accordingly.
So the time starts now.
Five more seconds. Ending the quiz. The correct answer is C.
Yeah. So here is a third question. Which of the following statements regarding the condition shown in the picture is false? This condition is unilateral, retinal vessels originating from periphery of the disc. Visual acuity is often good and RAPD may be present. You can start the quiz, Sunil.
The quiz is on the screen. Please answer accordingly.
Time starts now.
Five more seconds. Closing the quiz.
The answer is C. Visual acuity is often good. Okay, next question, please.
Should I move to the next one, sir?
Yes, please. We are short of time, so we have to hurry. Which of the following statements regarding the condition shown in the picture is false? Please show the options. So now here are 4 options. And you can start the quiz now.
The quiz is on the screen.
Time starts now.
Five more seconds. Please don't write anything on the screen.
This time nobody is writing in the chat box. Thanks for that.
Closing.
And the answer
This is the answer.
Yeah. PTT has been reported to be successful in treating this disease. And the
So
last
moving on to
question.
the next last question, sir.
Yes. The patient comes for a routine eye checkup. He doesn't have any visual complaints. His vision is 20/20. And the photo of his left optic nerve is shown here. What is the diagnosis? I think everyone should answer this question. Give the options.
Launching the quiz.
Yes.
Five more seconds. Closing the quiz. This is the correct answer.
Yeah, optic dysfusion. So thank you everybody for participating. And now you show the results of last time quiz, Sunil. You
Yes,
have
sir.
that slide. Yeah.
Yes, sir.
Yeah, please.
This is the top 6 in the rankings. I'm just putting it on a. Yeah, I hope it's visible.
Yeah, it is visible. So out of 55 who attempted last time, only 6 could answer all 5 questions correctly. And the fastest finger was Nehal Farke. Then it was Nehal Mehta, Naveen Bhandari, Priyanka Handrake, Anushka Kumbhar, and Prabjot Singh. So congratulations to all the winners and all the participants also. And I would like to thank everybody for taking forward this PG teaching program. Special thanks to Dr. Swapnesh for this month's topic Retina. As a coordinator, he has done excellent job. I would like to thank NI also, Dr. Aditya Kelkar, Dr. Zai Kelkar, and Dr. Nikhil Lakshetwar. And can you just show all the certificates?
Yes, sir. Yes, sir.
You can just run through those certificates. Those who have helped us in first session of Retina, which was held on 8th of December. And after that, we will straight away start with our journal club activity.
This is in alphabetical sequence, please.
Just run through it. Yeah, there's Nehal Mehta, Sheetal Bajoria, Swapnesh, Pritam Saran. Thanks a lot. So thank you. Now we move on to journal club activity. Dr. Vaishal is there. You can unmute Dr. Vaishal and Dr. Parul Deshpande. Sunil?
Yes, sir.
Dr. Vaishal Kenya and Dr. Parul Deshpande will be there. Dr.
Dr.
Vardhaman
Vaishali is there.
Yeah, Vaishal is there.
Dr.
You have to
Vaishali
unmute.
Une is there.
Not Vaishal Une, Dr. Vaishal Kenya.
Okay. So he's not there.
Yes, fine, actually.
Dr. Vaishal is not there, sir. Dr. Vaishali is there. Both of them are not there, sir.
If Bide sir allows, then I can conduct the journal
Yeah,
club.
you can. अरे तू join नाही झालेला का? तू He's joining in 5 minutes. Till then, if anybody wants to say something about this PG teaching activity and any suggestions, any students, any teachers who are there. Professor Une is there. I think she can comment on the teaching activity. They can suggest. Vardhaman, are you there?
So it's going very excellently, and I'm really glad that there are so many participants, and I am really thankful on behalf of all the PGs that we have started this venture, because the quiz is also great and the PG teaching sessions are also wonderful. So all in all, a win-win situations for all the PGs, that they are getting to learn not only like during the ward things, but even at their sitting in their rooms also they are getting to learn from the experts. So kudos to you and the team for starting this activity.
Actually, our reach is only less. Now we have only 80 people. I think there are 450 PGs. So we need more attendance next meeting for cornea, topic cornea on 4th of January. We should have more number of.
So definitely this will pick up, because if those residents who are joining, they will also ask the others to join, because this is definitely beneficial for all of them. And I'm sure like in the new year, we'll get tremendous response.
Dr. Swapnesh, your thoughts, please. Are you there, Swapnesh? I think Swapnesh is not there. Anyone else? Dr. Radhakrishnan. Okay, Radhakrishnan is there. Dr. Atul, I can see you. Atul Kadhane. You want to contribute?
Sir, definitely it's a very nice activity. See, I remember my PG days, so many things, though that time we don't have access to such things. So it's only a PG activity in the department, and on such platform with so many stalwarts here, even I feel it's learning for me also, though, because many times
Yeah, I
we
think we
also
should
learn.
have that for practicing ophthalmologists as well. We should encourage practicing ophthalmologists also to join this.
It's
I think
definitely
we have
helpful.
Dr. Nikhil Gokhale with us now, and he's there for our journal club activity, is the main. And for next month's topic cornea, he will be the coordinator, main coordinator. Dr. Nikhil, would you like to say a few words about this activity, PG as well as for practicing?
Yeah. No, only thing we are joining for journal club. Actually, we were joined on separate platform.
Yeah.
So I think we can
Actually,
start.
I had told Vaishal specifically that it's the same platform. But
Okay,
I don't know why he shared the other. In fact, I was sharing same link for both platforms.
Okay.
That becomes easier, no? Because
Yeah. So I think there Dr. Murli also will join us. So maybe we can start the presentation quickly, rather, because
Dr. Parul Deshpande has joined. So she can start the session. I think Dr. Parul, you can straight away start. Dr. Vaishal, have you joined?
Yeah, I have just joined. We can
Go
just
ahead,
straight away directly join the session.
Yeah. I have already welcomed everybody, and I have already told about the activity.
Good.
So you can say about this season 2 of Journal Club activity.
So Journal Club.
I would like to thank Vaishal and Dr. Parul and Dr. Nikhil Gokhale for this activity.
So this is the Journal Club meeting season 2. In the first season, we did 12 Journal Club meetings. So this is a joint initiative of MOS and BOA. So without further ado, I would ask Parul to continue.
So thanks, Vaishal. So today we'll be discussing about Peters anomaly. So Peters anomaly is a congenital corneal opacification of the cornea, where it's common in the infancy and early childhood, and it causes a lot of visual deprivation in these children. And the common therapies which are used for Peters anomaly is usually either the pharmacological pupillary dilatation, or peripheral laryngectomy, or rotational autographs, or the optical keratoplasties. So penetrating keratoplasty, as we know, does not have a very long-term success rate in these children. So a newer procedure, which is called as selective endothelectomy for Peters anomaly, has been described. And this procedure, this article basically, which we are going to discuss today, is going to talk about this procedure, its outcomes and its indications and its limitations. So with this, I would ask Dr. Shweta to take over and share her presentation. Shweta, are you around?
Yes, ma'am.
Yeah, Shweta, share your presentation, please.
Yeah.
Maybe we should introduce Murlidhar till she starts speaking. Maybe, I think a few words for our audience.
You can
Join.
introduce maybe. Nikhil, you can introduce.
Nikhil,
Should I start?
1 second, wait. I think we'll just
Yes.
introduce Dr. Murlidhar.
Yeah, he is the guest today from LV Prasad, no? So I think we should acknowledge his presence and introduce
I'd like
him
to welcome
briefly.
Dr. Murlidhar from LV Prasad, and on behalf of MOS, I would like to thank him for joining and giving his expert comments on this interesting topic.
I think he's not joined.
His name is coming there. He's joined.
It's coming? Okay.
Yeah. He's there. Okay, we can start.
Shweta, you can start the JC.
Good evening, everyone. I am Dr. Shweta, resident doctor from Lokmanya Tilak Municipal Medical College. Today, I am presenting an article on selective endothelectomy in Peters anomaly, a novel surgical technique and its clinical outcome in children. It is published by Dr.
We can't hear you, Shweta. People can hear?
Yes, ma'am.
I believe there is a network issue. Her video is also frozen. Dr. Shweta, can you close your video and then speak? Dr. Shweta, can you please close your video and then speak?
Peters anomaly is a developmental abnormality associated with the corneal opacities. Limited to cornea's posterior layer. The most common indication for penetrating keratoplasty among congenital corneal opacities. If untreated, it can result into sensory deprivation amblyopia. The management for Peters anomaly include conservative approach like in a mild central corneal opacification with mydriatic occlusion therapy. Peters anomaly with the most extensive central corneal opacities can be surgically managed with a variable success rate. Optical iridectomies, rotational keratoplasty, conventional full thickness keratoplasty, and primary keratoprosthesis are various surgical options in severe cases. Visually impaired Peters anomaly treated with penetrating keratoplasty is highly variable with the suboptimal long-term outcomes. Graft failure rates reported in 50% to 100% in 10 years and high incidence of post-operative complications such as allograft rejection, suture-related issues, wound dehiscence, and secondary glaucoma, which further compromises on long-term outcome. Selective endothelectomy in Peters anomaly is a novel technique for treating corneal opacities introduced in 2012. The basis of this technique is when peripheral endothelium is unhealthy, corneal endothelial defects heals rapidly after injury or insult. Recent literature supports the idea that peripheral corneal endothelium capable of self-renewing after dermatomyositis in Fuchs endothelium dystrophy. In a corneal endothelium at the edges and under the defect is abnormal and might inhibit centripetal expansion and normal healing, and the absence of the central corneal endothelium result in a persistent corneal edema and opacification. This technique showed a selective removal of abnormal corneal endothelium and promote corneal scar remodeling, eliminating need for full thickness keratoplasty. Depending on the clinical signs, the clinical categorization are done as type A Peters anomaly, where there is a central corneal opacity with peripheral iridocorneal adhesion extending from iris collaterate to the perimeter of the corneal opacity. Type 2 Peters anomaly is a central corneal opacity associated with keratolenticular adhesion, and it may result into rudimentary, fragmented, or partially absorbed lens. Peter plus anomaly, it is a bilateral peninsular-like corneal opacification. There is a posterior stroma and corresponding defects in descemet membrane endothelium complex with the systemic features. In ASOCT, there is a double-layered descemet membrane will be there, and in histopathology, a focal abnormal posterior corneal stromal architecture with a focal absence of a descemet membrane with markedly attenuated endothelium with uveal pigment deposits around the defect's edge. The purpose of this study is to describe the surgical outcome in a selective endothelectomy in Peters anomaly, and it is relatively a new technique to manage the Peters anomaly. It is a retrospective, consecutive, non-consecutive, interventional clinical case series. This study includes 34 eyes of 28 children who had visually significant posterior corneal opacity due to Peters anomaly and underwent selective endothelectomy between 2012 to 2019 at LV Prasad Eye Institute, Hyderabad. The children with Peters anomaly were evaluated for size and density of the posterior corneal opacity and visual improvements, and ASOCT was performed before and after the surgery in cooperative patients. The institutional ethics committee of LV Prasad Eye Institute, Hyderabad, India, approved this study, and this study was conducted in a strict adherence to the tenets of the Declaration of Helsinki. All the legal guardians of the patient, children's undergoing a selective endothelectomy and additional intervention gave the written informed consent for all the procedure in this study. The disease severity is graded as a mild, moderate, and severe. Mild disease is the presence of normal iris and lens. Moderate is when there is the focal iridocorneal adhesion and other iris defects like atrophy, abnormal vasculature, or coloboma. And severe disease when there is a corneal lenticular adhesion or corneal staphyloma with or without corneal lenticular adhesion. The corneal opacity are divided into 3 zones. Zone 1 is the central corneal opacity, where opacity with around the diameter of 5 meters. Zone 2 is a peripheral corneal opacity extending from zone 1 to limbus, and zone 3 is when there is a compromised limbus, and it is subdivided into 3A and 3B. 3A where there is a subtotal limbal opacification, and 3B is a total limbal opacification. Designation and laterality. The bilateral disease is considered when there is a visually significant corneal opacity in both the eyes, and unilateral disease when there is only one eye affected, or asymmetrical bilateral disease in which corneal opacity is in lesser affected eye is minimal or extraaxial or visually insignificant. The inclusion criteria for undergoing this procedure is a children with a type 1 or type 2 Peters anomaly with posterior corneal defect limited to zone A and visual function and precluding retinoscopy or fundus view under the undilated circumstances are considered for selective endothelectomy. The patients which have pancorneal involvement, zone 3B corneal opacity, anterior staphyloma, secondary glaucoma, microphthalmia, persistent fetal vasculature, aniridia, or those who are not consenting for the surgical intervention are excluded from this study. The preoperative visual documentation, corneal pachymetry, and ASOCT using handheld spectral domain OCT in under general anesthesia, or using RTView 100 Fourier domain OCT in office setting in cooperative patient are performed. In ASOCT, parameters like zone of extent of corneal opacity, iridocorneal adhesion, corneal lenticular adhesion, anterior chamber depth are evaluated, and alternative options including optical iridectomy, rotational autograft, and additional lens removal with concurrent and subsequent penetrating keratoplasty is discussed with the parents. The information regarding need of full thickness penetrating keratoplasty in near future is explained to the parents. The surgical technique is it is performed under hypotensive anesthesia. The by experienced corneal surgeons. First, there is the anterior chamber is filled with sterile air, and carefully with the help of trypan blue dye, the extent of corneal opacification is delineated. DM duplication is removed, and if there is any iris strand or lens opacification is there, it will be cleared. Using bimanual eye cannula, the unhealthy corneal endothelium from opacity under surface and at the edges was gently scraped off up to 1 mm into the normal corneal without disturbing the descemet membrane's integrity. Trypan blue restaining along with the chandelier light pump used to identify the descemet membrane tears or detachment. Additional intervention like iris tissue adhesionolysis, optical iridectomy with sphincterectomy, even corneal opacity is more than 6 mm, obscuring the retinal red reflex without dilatation. Selective endothelectomy with lensectomy is along with the primary posterior capsulotomy, and limited anterior vitrectomy may be performed. All incision sites are sutured with 10-0 nylon. Post-op patient is on a topical moxifloxacin 0.5% eye drops, prednisolone acetate 1% eye drop, and atropine sulfate 1% eye drops are instilled. For follow-up, a patient is followed for first 4, 12, 24th, and 52nd weeks after the intervention, and after that 1 yearly follow-up is done. Slit lamp examination for cooperative patient and examination under anesthesia for younger and uncooperative patients using handheld slit lamp is done. During the follow-up, the assessment of corneal clarity, visual acuity, refraction, and retinoscopy is performed. Side port sutures are removed after 3 to 4 weeks, and until then, the patient is on will be maintained on moxifloxacin 5% eye drops and prednisolone acetate, starting with 6 times a day, followed by tapering over next 6 weeks. Spectacle prescription between 1 to 2 weeks, or as soon as corneal clarity allowed reliable retinoscopy readings, then it will be prescribed. Amblyopia managed using occlusion therapy and optical correction with glasses or contact lenses, or both with under attending surgeon's direction or pediatric ophthalmologist. If IOP is elevated, topical, or if needed, systemic glaucoma medication is used. And glaucoma filtering surgery is reserved for only for those eyes where IOP still have a maximal still elevated with a maximal medical therapy. Intraoperative and postoperative complications were reviewed with the patients, and during the first year after the surgery, patients were contacted by telephone, and if they missed any schedule visit, and next earliest appointment will be arranged for them. This was performed proactively to ensure that all patients complete their first year of follow-up. This is the photograph of a 6-month-old child. This is the right eye of this patient. Is pre-op pic. This is the after the post-op day 3 pic, where we can see after the selective endothelectomy there is a corneal edema. This is the this is a follow-up for 1 month peak, and this is the 4th month. We can see there is a reduced corneal edema. This is the 8th month peak, and this is the 16th month peak. We can see there is a corneal edema is very much reduced, and this is the same patient with the left eye selective endothelectomy is performed. Data collection, it included patient's age, sex, laterality, detailed pedigree, and details of prior any eye ocular surgery done, duration of corneal opacification, preoperative visual acuity, IOP, intraoperative surgical details, postoperative complications, length of follow-up, status of descemet membrane, IOP, and optical nerve head health at each visit is performed. Visual acuity measured using age-appropriate grading, acuity in infants, and acuity cards in young children, or linear Sloan letters in older children. Blink or grimace to light was defined as a light perception. Center, steady, maintain, or fix and follow were defined as a hand motion. Visual acuity values were converted into logarithmic of the minimum angle of resolution equivalence. The impact of laterality, preoperative age at the surgery, size of opacity, any additional intervention, and postoperative factors on the clinical resolution for corneal opacification is analyzed. Outcome measures of efficacy. Primary outcome measures was clinically significant resolution of corneal opacification after the procedure. This was defined as a partial to near total stromal clearing without epithelial or stromal edema, allowing the clear view of the iris feature, retinoscopy, or fundus examination. Failure when there is a no clinical resolution even after 3 months after the selective endothelectomy, precluding the visibility of iris details, retinoscopy, or fundus examination, and there is a need for additional intervention for visual rehabilitation. Secondary outcome measure of efficacy was improvement of the best corrected visual acuity at each post of follow-up visit. The cases are categorized based on the clinical resolution of corneal edema and scar remodeling as a cleared, partially cleared, or not cleared. Cleared when considered when there was a complete resolution of a corneal edema with a discernible scar remodeling by 3 months that allowed decent retinoscopy reading in undilated condition. Partly cleared when significant clearing but needed pupillary dilatation for a retinoscopy reading by postoperative 3 months. And not cleared when there is a no change in corneal opacity, density, size, where refraction was possible only after dilatation or through optical iridectomy using opening, and was classified. These patients are classified as a non-responders. Validation of a diagnosis is by 5 proficient ophthalmologists, including 2 glaucoma specialists, a pediatric cornea specialist, and 2 cornea surgeons, volunteered as the evaluators to validate the investigator's assessment of the type 2 Peters anomaly and outcome of the surgical intervention in every case. They are provided with the pre-op and post-op photograph of the patient, and they are asked to evaluate the photographs based on the objective criteria like visual acuity, grading of the disease severity, zone of the corneal opacity, designation of the laterality, and outcome measures of efficacy. Information regarding the patient's identity and type of surgical intervention performed were masked, and if there was any disagreement between the evaluators or surgeon, independent evaluator's opinion was taken as a final diagnosis or a treatment outcome. Statistical analysis is performed using Stata V14.2. Distribution of continuous data was tested for normality using Shapiro-Wilk technique, and continuous normally distributed variable were represented as a mean plus minus standard deviation. Median interquartile range were used to describe the continuous non-parametric variables, and categorical data were expressed in proportion. A mixed effect model with a random intercept at the subject level were used for correlation between the fellow eyes of the same patients in the comparison between the visits and in the analysis of the risk factor for failure. In addition, the outcome data were compared among the types of surgical intervention, whether selective endothelectomy alone or with or without synecholysis, or with optical iridectomy, or and with the lensectomy. The p-value is less than 0.05 was considered statistically significant. Results during the study period between 2012 to 2019, out of 34 eyes, 28 children diagnosed with a posterior corneal opacity due to Peters anomaly underwent selective endothelectomy with or without additional intervention. Out of which 17 children were males. Parental consanguinity was noted in 19 children, and 19 eyes out of 13 children had a visually significant bilateral disease for 55.9% of cohort study, while 15 eyes of the 15 children had a unilateral involvement. Mean age at presentation, sex, laterality, consanguinity, zone of involvement of the opacity, and preoperative base corrected visual acuity were comparable among the interventions. And the selective endothelectomy with optical iridectomy, and selective endothelectomy with lensectomy, and all eyes with the type 2 Peters anomaly underwent selective endothelectomy with lensectomy. The mean age at the time of this procedure was 2.06 plus minus 0.51 years, and the 24 eyes were in children who were younger than 12 months at the first intervention. The post-interventional mean follow-up period was 0.96 plus minus 0.2. The selective endothelectomy with the lensectomy with limited vitrectomy was performed in 9 eyes, out of which the 2 eyes has an adherent lens, 3 of them has a rudimentary lens, and 3 has a cataract lens, and 1 has a partially absorbed lens. Efficacy of selective endothelectomy. As earlier, they are divided and cleared. In out of 34 eyes, 11 eyes has a significant clearing of corneal opacity, and these eyes are maintained a clear optical axis with a gradual reduction in the density of the corneal haze, which was evident in 3 months post-intervention. And beside having overall corneal diameter, expansion of overall corneal diameter, no further reintervention was necessitated in this patient. Partly cleared is 18 eyes has a discernible change in the corneal clarity and acceptable functional vision. Refraction possible in this patient after pupillary dilatation or through iridectomy opening. Post-operatively, there were no glare or photophobia complaints in these patients. 5 eyes who failed to show any discernible resolution of corneal opacification. All these eyes had a severe disease involving zone 3A, and in this patient with a severe bilateral disease affecting zone 3A, it was found after 3 months after the first surgery that the clear optical zone was very small, and therefore optical iridectomy did not give any adequate red reflex. In this patient, the children's parent did not consent for keratoplasty due to severe hydronephrosis, and after the repeat large sectoral iridectomy, child regained decent ambulatory vision. Post-operative visual function, among 34 eyes at the presentation, only 1 eye had a vision better than 20 by 190. 20 eyes had ambulatory vision and 13 had a non-ambulatory vision. Post-intervention, 24 eyes had a non-ambulatory vision and 8 achieved a base-corrected visual acuity of 20 by 190 or better at the final follow-up. Suboptimal visual improvement was due to dense amblyopia or near total corneal opacification. The patient with the bilateral type 2A, type 2 Peters anomaly had a 2-line improvement in the visual acuity compared to baseline after the large sectoral iridectomy. The mean spherical equivalent refraction at the final visit was 5.08 plus minus 1.18 diopter. The eyes undergoing selective endothelectomy and selective endothelectomy with lensectomy had a significant improvement in the visual acuity at the final visit when compared with the preoperative. Safety of this procedure, none of the eyes had received none of the eyes that received this procedure or its iteration had DM detachment, persistent corneal edema, or lens touch or UVL trauma. Most common observation in the operated eye was a corneal edema at the site of this procedure. And the corneal edema resolves spontaneously within 1 month post-operatively, and it is demonstrated on ASOCT. The ASOCT confirmation available in 23 eyes. There is no sight-threatening complication documented, and none of the eyes had a decline in visual function post-operatively. 5 eyes who had a persistent elevation of IOP after intervention, despite excluding the eyes with preoperative glaucoma. 4 eyes had a severe disease and other 2 had a mild to moderate disease. And patient who had severe disease but corneal involvement limited to zone 1 have shown marked improvement in the corneal haze. AMAT glaucoma implantation in the left eye was required to achieve the adequate IOP control in that patient. Post-AMAT glaucoma valve intervention, the corneal decompensated and corneal grafting was deferred in view of dense amblyopia and contralateral aphakic eye that had best corrected visual acuity 6 by 15 or better vision, and the remaining cases were treated with a topical anti-glaucoma medication alone. ASOCT analysis, it is done pre-intervention and post-intervention in 8 eyes. And the preoperative image analysis revealed the Bowman's membrane over the corneal defect appeared either disrupted or absent, while the rest of the anterior chamber architecture was comparatively preserved. Overlying the DM defect, the posterior stroma had a denser reflectivity with a varying degree of stromal thinning and excavation. Edges of the defects were thickened and rolled out. Few cases showed the presence of anomalous pre-descent layer occupying the posterior concavity, and numerous delicate iris strand extending between the iris collaterate and the edges of the corneal defect. In post-intervention ASOCT, the corneal edema in the immediate post-op period and intact DM with a healing pattern was observed in subsequent ASOCT analysis. Resolution of opacity after this procedure using bivariate analysis, female sex, disease severity, glaucoma, and additional intervention after the selective endothelectomy were significant risk factor for the failure of this procedure. And in multivariate analysis, disease severity was significant and risk factor for the failure of this procedure. Agreement between primary surgeons and independent mask evaluators. The overall agreement between the mask evaluators and the primary surgeons for the primary diagnosis of and preterm anomaly type are 100%, and the concordance kappa measures between the primary surgeons and mask evaluators for the treatment outcome range from 0.15 to 0.61, suggesting they were fair to good. discussion. It's a selective endothelectomy. It is a novel, less invasive strategy to treat the corneal opacity in a children with Peters anomaly. It is based on the focal area of anomalous DM endothelial complex underlying the posterior corneal defect, and pre-lesional healthy endothelium has a regenerative potential to fill the denuded area. Robust scar modeling in children and relatively well-preserved anterior stromal architecture. The anomalous endothelium inhibit the normal expansion of the surrounding peripheral cornea and the endothelium, leading to localized loss of endothelium pump function and corneal edema. Therefore, it is believed that it could be improved if the abnormal endothelium is removed and resulting in the defect being replaced with the healthy pre-lesional corneal endothelium. The recent study shows that after the localized corneal endothelium removed, the neighboring cell will enlarge and migrate to restore the anatomic and functional integrity of the corneal endothelium monolayer. Selective endothelectomy, while preserving the descemet membrane, might promote the spontaneous endothelial migration, thus simply accelerating the spontaneous resolution of corneal edema and opacification, and consequently invading the limitation of penetrating keratoplasty in children with Peters anomaly. Type 2 Peters anomaly variant often requires lens-induced intervention followed by penetrating keratoplasty associated with comorbidities necessitate further intervention that in turn compromises the long-term graft survival. Alternatives for penetrating keratoplasty include pharmacological dilatation, rotational corneal grafts, and optical sector iridectomy, and spontaneous resolution, which have had different success rate. In this case series, the surgical approach in each case was governed by disease severity, associated comorbidity, child's visual potential, and parents' expectation and surgeon's preference. In the surgical cohort, out of 29 eyes that had undergone selective endothelectomy with or without additional intervention showed partial to near total corneal clearing and discernible change posterior to stromal architecture, indicating the endothelial cell healing pattern observed using Fourier domain optical coherence tomography. In 5 eyes of 3 children where cornea failed to show an improvement, by 3 months after the selective endothelectomy with lensectomy, a large zone of involvement was seen in contrast to eyes which had a successful outcome. A large zonal involvement of around 4 to 6 mm requires more than double the surface of for remaining endothelium to repopulate, and by contrast, around 8 mm defect may require repopulation of 4 times that of the area of 4 mm of endothelial scraping. Ideal case selection for this new technique is for mild to moderate Peters anomaly cases with a smaller zonal involvement, less than 7 mm. And most eyes with a successful outcome showed a marked reduction in the corneal edema within 1 month of this procedure, and central corneal haze shows gradual decline in ranging from 6 to 18 months. And this suggests that the eyes with a dense opacity within the surgical cohort showed the considerable time for stromal clearing and scar remodeling. During this period, children must be monitored closely for amblyopia. If there is no significant improvement in the corneal haze based on the clinical judgment, consideration should be given to perform optical iridectomy and penetrating keratoplasty. After the selective endothelectomy, the vision continued to improve in 32 eyes with a longer follow-up duration. Besides, the vision continues to improve with the age owing to visual maturation in growing children. ASOCT analysis revealed well-preserved anterior stromal architecture helps to achieve faster refractive stabilization in penetrating keratoplasty. Penetrating keratoplasty has an inferior long-term outcome and merited stringent follow-up and had a risk of graft infection, allograft rejection, secondary glaucoma, suture-related issues, astigmatism, graft host dehiscence, and re-intervention if graft fails. The severity of the disease, presence of microcornea, high IOP, concomitant lens aspiration with vitrectomy, and female sex are the risk factor for this procedure. And inadvertent descemet membrane detachment at the time of selective endothelectomy should be avoided, because it then additionally we have to do other intervention which in turn adversely affect the this procedure's outcome. Therefore, it may be advisable for identify those eyes with a wider corneal involvement corneolenticular attachment, ectasia, extremely thin cornea, perforation, and staphyloma formation by performing a OCT or ultrasound biomicroscopy before surgery. These studies measure strength are sample size, single center design with the experienced pediatric corneal surgeons and long follow-up. 5 independent mask evaluators validate the diagnosis and the outcome were assessed in every case. And the other more objectives means such as ASOCT or image analysis of post-op outcomes could have been used. This procedure should be offered as a preferred surgical modality in all the children with Peters anomaly or only in a select case where penetrating keratoplasty is not preferred alternative, such as where there is a donor tissue is not available, non-compliance of the patient, inability to follow up or high-risk cases. And this study shows that the selective endothelectomy results are extremely promising and it can be effective surgical alternative to optical iridectomy and full thickness penetrating keratoplasty, benefiting hundreds of children with Peters anomaly related blindness worldwide.
Thank you, Shweta.
Thank you, Shweta. Yeah, and I would like to thank BOA and MOS for giving the opportunity to Dr. Parul Deshpande ma'am, panelist, and our HOD ma'am also, for Dr. Chachinde for giving me the opportunity to moderate the session. And I am sure that now everyone would be curious to see the actual video, how it is done. So I would like to request that if we can see the surgical video.
Just a second, I'll just see this. I'll just share the link 1 second. Is Syed there? He can share.
Yeah,
1 second, I'm not able to open. Yeah, okay. Yeah. So this is the video.
May make the full screen now.
Yeah.
I shall be presenting our work titled Selective Endothelectomy in Peters anomaly, acronym title SEPA. The long-term clinical outcomes in 34 eyes of 28 children with Peters anomaly. None of the authors have any proprietary or commercial interest in any of the material discussed in this particular study. As we all know, Peters anomaly is the most common anterior segment developmental abnormality, presents with central or paracentral corneal opacification. It accounts for nearly 50% of the children born with corneal opacity. Bilaterality is seen in 2/3 of the cases. Incidentally, is also one of the most common indications for a corneal transplantation among congenital corneal opacity. This is a typical case of type 1 Peters anomaly with the posterior excavation, which is evident on an anterior segment OCT as well. In this particular instance, wider zone of cornea is involved. On UVM, you could actually see the perimeter of the corneal opacity having a synovial attachment.
You cannot see the
Clearly
video.
evident on horizontal and vertical scans of the UVM.
Only the
This is a
audio is
typical
audible.
case of keratoirodolenticular where right and left eye of the same child.
Hello.
Left eye has a
Hello.
Video is not running, Parul.
1 second, 1 second. Yeah.
We
Parul, the
can't.
video is not running.
We can't see the
Not
video.
running.
No, video is not seen.
ma'am, audio is going on, but the video is not visible.
Okay,
You need to play the video. Please play the video. Video is not
Play the
played.
video. Yeah.
I'm sharing the screen and the screen is showing.
Sharing is okay, Dr. Parul, but you need to play the video.
Yeah, I'm able to see the video here running. That's why.
No. First open the video and then share the screen.
Yeah, I had opened it.
Once you open it, then pause it and then share the screen.
Okay.
Very good morning. Myself, Muralidhar Ramappa.
Yeah, can you see now the video?
Yeah.
Okay.
I shall be presenting our work titled.
No. Again, it went off.
Anomaly,
Okay, so whenever I'm
acronym
making
title
a big screen, it's not coming. Now you're able to see?
comes in
Yeah.
34
No,
eyes
no.
of 28
Actually,
This is
don't
centimeters.
clearly what
maximize
we
it.
are
The moment you
seeing.
None of the
maximize it, it
authors
is
have
stopping.
any in India.
Can you see now?
Yeah, it is okay.
Now, yeah,
As we
please.
all know, Peters anomaly is the most common
No,
anterior
actually,
segment
we are seeing
developmental
the PPT.
abnormality,
We are not
presents
seeing
with
video.
central or paracentral corneal opacity.
So you stop sharing, you open video, and then start sharing.
Now,
50% of the children born with corneal opacity. By
1 second. I've done that, but
Dr. Parul, first
can you see
maximize
it?
it, then do the screen share. First maximize it.
When I
Stop
maximize
the
it, okay.
stop the share first. Stop the share. Maximize the video and then do the screen share.
Okay, 1 second.
And so YouTube video, chances are you will have issues playing it.
Okay, I've done this. 1 second, huh? You want me to?
Just do Alt Tab. You should be able to
1 second.
on the keyboard. Do Alt Tab. You should be able to come to Zoom window
Okay, now
on the
see.
keyboard.
No, now I can open and see if you're able to see. It's a full screen.
No, it doesn't come in the full screen. So you will have to play it like this only. The moment you do full screen, the video stops.
Okay, now
this,
can you see it here?
incidentally, it is also one
Yeah,
of the
we
most
can
common
hear and it's playing.
indications for a corneal transplantation
Let it
among
run like this then.
congenital corneal opacity. This is a typical case of type 1 Peter anomaly with a posterior excavation, which is evident on an anterior segment OCT as well. In this particular instance, wider zone of cornea is involved. On UVM, you could actually see the perimeter of the corneal opacity having a synovial attachment, which is clearly evident on horizontal and vertical scans of the UVM. This is the typical case of keratoiridolenticular dysgenesis, where right and left eye of the same child, where left eye has a severe involvement with the cataract. While conservative approach applied in a milder variant of Peters anomaly, where surgical interventions are typically resolved in a severe cases of Peters anomaly, often have a abysmally poor outcome. While small subset of milder Peters anomaly tend to spontaneously recover over a time, but majority may not show a discernible clearing owing to presence of anomalous layer as shown in this particular slide. Histopathologically, the posterior defect filled with a uveal tissue and anomalous fetal membrane, as evidence in these histological slides. Perhaps this particular layer inhibits the normal endothelial migration, thereby preventing the spontaneous recovery. Based on our clinical as well as histopathological observation, we felt there is a focal area of anomalous Descemet's endothelial complex underlying the posterior defect, which perhaps serve as a contact inhibition. Once we remove those anomalous layer, the perilesional healthy endothelium tend to regenerate and fill the denuded area, lead to the resolution of the corneal edema. And also robust scar remodeling in children together with overlying well-preserved anterior stromal architecture helps in the rehabilitative journey of a child. We documented the postoperative healing response after CPA using high-resolution anterior segment OCT. At 1 month postoperative follow-up, DM is not only well opposed, the endothelium was covering the defect, which is sharply demarcated. Together, clinically, we could actually perceive stroma is much more compact and transparent postoperatively. Our intent was to determine the functional success of CPA in children with Peters anomaly. This was a single-center retrospective consecutive interventional case series. The study included 34 eyes of 28 children with visually significant Peters anomaly that had undergone a selective endothelial removal with or without additional procedure. The study was conducted at LV Prasad Eye Institute, Hyderabad, India, over a period of 8 years between 2012 and 20. Based on the location and extent of the corneal opacification, the corneal opacity can be categorized into the zone 1, which is a central island of corneal opacification within central 6 mm. Zone 2, central cornea with a peripheral cornea is involved. Zone 3A is a near total corneal opacification. Zone 3B, complete corneal opacification. This is a technique demonstrating selective endothelectomy Step 1, severing the communication between iris and cornea. Step 2, identifying the actual defect. Third step, delicately removing the anomalous corneal endothelium without disturbing the integrity of Descemet's membrane. Step 4, checking the integrity of Descemet's membrane. There was no Descemet detachment at the end of surgery. Type 2 Peters anomaly, wherein additional lens aspiration along with sphincterotomy was considered in view of a large corneal opacity. The sequential picture collage of a milder variant of Peters anomaly, right and left eye of a same child, showing the postoperative corneal edema resolution with a scar remodeling as observed over 18 months period. In contrast to the top row, wherein had an extremely good outcome with a smaller zone of corneal involvement. The bottom two rows had a wider zone of corneal involvement that resulted in a suboptimal outcome following this intervention, which was observed over a period of 6 months' time. The sequential picture collage of severe Peter anomaly, top and bottom row showing a significant improvement in eyes with a smaller zone of corneal involvement compared to the middle two rows where corneal opacity is much larger along with a cataractous lens had a suboptimal outcome with a secondary glaucoma. Meaning even in a type 2 Peters abnormality with a smaller zone of corneal involvement can help achieve a good outcome. Primarily our cohort included a type 1 abnormality. Median age at surgery was 7.2 months and 85% had a discernible corneal clearance. So the 97% had ambulatory vision and BCVA significantly improved owing to the resolution of the corneal opacification. On careful evaluation for the factors responsible for a SEPA failure, we found that one is severity of the disease, the zone of involvement, and additional intervention seems to be the important risk factor for the non-resolution of the corneal edema. 85% of the mild to moderate cases had a significant corneal clearing in comparison to the severe disease. The cornea tend to clear even beyond 12 months, so perhaps this may be related to the remodeling ability of the younger children. Over the last 3 decades, the literature primarily focused on anatomical success has shown a modest outcome, and only 20 to 60% of them achieved a 2400 or a better vision at a median follow-up of 4 years. The current study, where most cases have actually showed a significant improvement, and vision is continued to improve over a period of time. Our study validates the long-term outcome of SEPA. It's a novel, less invasive surgical strategy for the treatment of Peters. In 85% of the cases, opacity is significantly cleared with a marked improvement in the visual functions. We've also demonstrated to the best of our knowledge for the first time that SEPA can be used even in cases with the severe form of keratolenticula adhesion as long as the central corneal opacity no more than 7 millimeter or at least half of the peripheral cornea has remained clear. The findings of our study questions the prevailing paradigm whether this procedure could be offered as a preferred surgical modality in every case of Peter anomaly or only in a select cases where corneal opacity less than 7 millimeter irrespective of the type of Peters anomaly. The long-term results are extremely promising, can be a very effective surgical alternative to penetrating keratoplasty, and this would benefit hundreds of children with Peters anomaly related corneal blindness worldwide. Thank you for your kind attention.
Yeah, it was a wonderful video, Dr. Murli. So, Dr. Murli, can we have your expert comments about the procedure that you have discussed, So if you could have your expert comments about this procedure and its outcome.
Yeah, thank you, Viboye. Thank you, Dr. Parul and Vaishal for having me here. Can you hear Dr. Parul?
Yeah, very much.
One of the premise of this surgery is that it facilitates the normal healing. So all I have to remove is that, the central posterior defect where you have an abnormal cells, which otherwise serve as a contact inhibition, right? So once we remove these cells and all that, we're facilitating the natural healing process. Because having performed over 200 pediatric transplantations exclusively for a Peters anomaly in the last 17 years, I've seen when we looked at the long-term outcomes At the end of first year, only 22% of these grafts had a clear vision. And even with that 22%, if we look at in terms of functional outcome, less than half of them had a 2200 or a better vision. Meaning, keratoplasty is a big liability for a child and a family. And even in the best case scenario, keratoplasty will not, survive beyond 15 years, as you really understand. And nearly 50% of these cases end up having a glaucoma as well. And these children have a multitude of both ophthalmic and systemic associations. At times, some of these children need 7 or 8 systemic surgeries, right from cleft lip, cleft palate, cardiac anomaly, cochlear implants, genitourinary abnormality. So it is endless, the saga of events for a family. And nearly 60% of these children have had a kind of autistic spectrum. And that's one of the reasons why we were always looking for some alternative to the conventional keratoplasty, since keeping the graft clear is a Herculean task in terms of a stringent post-operative follow-up and need for a long-term medications. When you use such a medications for a long term, obviously you have a lot of complications related to the steroids as well. Some of these cases even have early on, when you use every hourly steroids in a young infant, they do have a pseudo-Cushingoid syndrome. Right from there, you can have a multitude of steroid effects on them. It could be, steroid-induced cataract, glaucoma, and so on and so forth. And to the date, I have performed little over 120 children's. And this was the initial series where Dr. Nikhil was also one of the, devil's advocate, meaning, he was one of the most observer. He not only helped us, compiling, this outcome along with the 5 other, clinicians. And we have a second paper that is an extended outcome of 10 long years, about again 45 eyes of 40 children. And a prospective trial, we just completed about 65 recently. I presented in American Academy of Ophthalmology meeting. We have, as I said, a little over 60 children. And these children were selected based on my new nomogram, and we have 100% outcome. Meaning in a carefully chosen case, we can not only eliminate the need for a corneal transplantation, with the one single intervention, you can actually take care of this abnormality. Most cases end up having extremely decent vision, and you don't need a steroids, you don't need a stringent post-operative follow-up as in case of keratoplasty. And you overcome all complications related to the corneal transplantation, and also you don't need a high quality, donor tissue. So that's how we are going. The future prospects in this particular case is really good, and hoping the similar the methodology or a surgical strategy can be applied to the other indications as well in the future.
So Dr. Murli, if you can share your indications, because you said that you've been having a very good success rate. So if you could share us the indications where you would definitely do this procedure over the other.
Yeah, this is a categorization. I hope you can see the slides, yes. Right? So I made a distinction, mild, moderate, and a severe, based on the zone of involvement. It could be a primary, the type 1, wherein it may be limited to the cornea with the high-risk strands, type 2, where you have a lens involvement. So as long as, you have at least, 1 or 2 quadrants of peripheral cornea is clear, this works. The first case is a very ideal case. I'll just come to, if you could look at this particular case. So the way Sweta was showing up to, 1.5 year, 18 months in a picture. Now, can you look at the, 4 years after this child has come, the bottom picture showing the pre-op and a post-op. You can hardly see any opacity post-operatively. This child is from Dubai. Parents are doctors. They've lost follow-up during the COVID because of some personal reason, and they were not using any glasses, patching. Yet, the child has a well-centered fixation with a 20/63 unaided vision.
Very nice.
So yeah, so I'll also show you, there are multiple such cases. These are all basically essentially type 2 abnormality, where you have a keratolenticular adhesion. And yes, so yeah, we've done these cases. As I said, we finished 120 children's. I'll just show you the recent pictures. I'm sorry. Yeah. So even, this can be used in, since, once I gained that confidence, we slowly expanded to even a much denser opacities. In a long run, this particular intervention seems to be superior surgical alternative to the keratoplasty. If you can look at even the last picture, some of the, initially I was, not believing myself, this would work in such a dense opacities, but it is gratifying to see these these children have amazing, remodeling ability once the corneal edema subsides. So that's how, the cycle goes. So the indication, as you rightly said, one is a zone of involvement. It should be limited to the posterior defect, meaning if you have a pan-corneal thickness, if you have a corneal ectasia, staphyloma, have a secondary glaucoma, extreme microcornea, this procedure should be avoided.
Thank you. Dr. Nikhil, you were a part of this study too. So could we have your expert comments also?
No, in fact, I just typed that, would there be any role of, maybe ask Dr. Murli, of Rho kinase inhibitors? Because maybe will they help faster resolution, or, is that a thought process in your mind?
Excellent question, Dr. Nikhil. So yeah, Rho kinase inhibitor, particularly used in a Fuchs.
Yeah.
Where you have, basically mutations in a particular gene where these endothelium are abnormal. Whereas this Peterson anomaly is a transcriptional abnormality, meaning, these cells, stop proliferating or maturating at certain stage in the central part, or where iris or a lens fail to separate from the cornea. Since peripheral endothelium are healthy, and based on our, the lab work, here I may not be able to show that work. So it's not necessary. That's what we felt. Ken Nischel, Deepak Edward, who are assisting me with this project. At least in a Peters, we don't need. We don't need this one since, peripheral endothelium are functionally normal. B, as you rightly know, the ROCK inhibitor, most children's, even in fact, adults, they don't tolerate. In terms of
we can hear you.
Yes. Yeah. In terms of, the tolerance of this topical medication is extremely poor. It is almost similar to, you can say, Alphagan. Most children, they don't tolerate. So those are all two possibly, impending factors why we did not use. In a prospective study, we had clearance, if it is a defect is a, let's say 4x4 millimeter, it takes about 3 to 4 weeks. If the defect is a 8 millimeter, it takes about 12 weeks for a complete resolution of the defect. That is a time for endothelization. And if we have an extreme microcornea, let's say microcornea where relatively the defect is much bigger, they don't do well. So also fact that, when we intervene, these children may be infants, like between 4 to 6 months is a time when we intervene, then the cornea is, expanding. The corneal diameter is around 9.5 millimeter at birth. So in a 3 years time, it will expand to 11.5, meaning, other 2 millimeter. If you look at the surface area, will be much bigger. So even if the opacity per se doesn't, resolve completely, because of expanded cornea will allow the much bigger peripheral, clear cornea. So that will enable the child to see well.
Thank you. I think we have the statistical expert, Dr. Maninder Sethia. So I just would like.
Just can I ask one question? Any role of endothelial keratoplasty in cases where the CEPA fails?
Yeah, they have attempted, Dr. Vaishal. There are two cases which I haven't done. So it is published from US by Robert Pineda. I think, they didn't have a good outcome. They have to go for penetrating keratoplasty later on. because the interface had some problem in those cases. They tried to strip the Descemet's membrane. They in fact peeled the posterior stromal layer, so interface was extremely poor.
Okay.
But in
Great question.
the posterior concavity that we see in these patients, does it pose a challenge as far as the visual recovery is concerned? So
Yeah,
do we not
extremely
understand that
good.
EK should benefit in these cases because
Yeah.
it cover that?
Yeah, it's extremely good question, Parul. So for us, cornea, you see it accounts for nearly 2/3 of the resolving power of the eye. The tear film ear interface is the most important. Even for instance, in a LASIK or when we do anti-lamellar keratoplasty, you have a very dense interface. It does scatter some amount of the light, but they do extremely well. The posterior concavity is much more well tolerated than the anterior surface aberrations.
Okay. So we have Dr. Maninder Setia. Maninder, can we have your comments?
Yes, so there were just a couple of comments. I think it's a very well done study. Now, my main comment was that the outcome was assessed by masked evaluators.
Correct.
But you've given the concordance between the surgeon and the masked evaluators.
Right.
What
So
was
what
the
I did.
concordance between the evaluators?
So, okay, can you come again your question, please?
So in the concordance and agreement,
right,
the last paragraph,
Correct.
You've given the agreement between the masked evaluator and the surgeon.
Correct.
But the outcome was assessed by evaluators. It was not assessed by surgeons.
No, it's both. Maybe
It's
the
both. It's
interplay
both.
of the words. So I'll tell you. Let's say if we take an example, can you see an arrow which I'm pointing you?
No.
Picture? Can you see the picture here?
No, we can't see the picture.
Oh, okay, right. So this has been right. Okay, let's say for instance, when what I did is a masked evaluators, where we did not give them diagnosis, we did not give the interpretation.
Yeah.
And what my statistician did is, so I had given my interpretation. This is a case 1. This is a severity is a mild, moderate, whatever case 1, which is resolved or not resolved, or a success or a partial success. That's what my interpretation. This information was not given to Dr. Nikhil. So Nikhil made a interpretation based on the criteria we sent to him. So he said, it is a partial success, complete success based on all criteria.
So the agreement is between you two people.
No. One is a surgeon, myself, primary surgeon. Okay, and remaining we compared my outcomes with all the masked observers.
So did all the masked observers observe each and every case?
Yes. So Nikhil is here. Dr. Nikhil is here.
So there were 5, because this is not clear in the methodology in the paper.
Right. No, they made me cut. I'll tell you, it underwent 9 revisions. It took 2 long years for the revision. You can see the manuscript. They trimmed the entire thing. The language experts from a cornea, they trimmed each time.
How did you get an agreement? So your agreement is between 5 evaluators and yourself for each thing, or it's an agreement between one evaluator and yourself?
Okay, that's a good question. So what my statistician primarily did is, so my interpretation, diagnosis, type, and severity, what is a success, whether it is partially success, it's completely success.
Yeah, that's fine. Yeah.
So that he has compared with, let's say we had 6 observers. If I say score is a 1, how many of them scored 1? Okay. So for instance, Nikhil was also there. If I say it is partially success, if even Dr. Nikhil partially success, that's how agreement was taken.
Okay, so it's not agreement 1:1.
Correct.
It's not 1:1. So then you had a lot of, but then in the methodology, you've mentioned that if there was a disagreement, a senior surgeon was called in, a third person was called in. There is somewhere in the methods you've mentioned that. I don't know, maybe that's just an additional point. That's just a thing. So now I get the thing. So maybe this could have been one of the, my only concern is that there is no limitation in the paper. And this is one of the major limitations, the way you've calculated the agreement. Because the agreement doesn't go beyond 0.61, which is not necessarily, I mean, yeah, it's technically good agreement, but it's almost borderline good because 0.60 is good. So that for me is a major limitation because your entire analysis is based on this agreement.
Correct. So the reason is, it's a photographs, when I share.
Yeah, fair enough, fair enough. No, I agree. No, I completely understand. My only point is that could have been added as a limitation of the paper.
I think, they've most of the thing they've chopped up, we
Okay,
possibly,
fair enough. And my other point is that you mentioned that you use a random effects model, but in my analysis, I could not see the model or the estimates from the model. So I could not understand what the model was used for what. Was it used for agreement or was it used for association? So those are my only 2 points. Otherwise, it's an excellent study and an excellent paper. I mean, if I would have been the reviewer, I would have asked you for these 2 clarifications. That's it.
Right. Thank you. Well taken, sir. Yeah.
Sure.
So I'm actually going back to the clinical question a little bit. Since there is a long-term follow-up recovery phase, so how long do we wait for the cornea to clear to it consider as an alternative modality of treatment, like penetrating keratoplasty or optical iridectomy?
Yeah. So let's say this is a best case scenario. So you people all see this slide?
No, we are not able to see.
Oh, okay. Maybe I think I've exited share screen. What about now?
No.
Oh, I'm sorry. Let me see if I can share the screen.
So, Dr. Murli, what was the youngest age group that you have done?
Yeah, youngest child I have done is a 6 weeks old. I don't intervene before 6 weeks. And 6 weeks is an ideal time. By then, blood aqueous barrier, everything establishes. And also for a surgical, the child will be at least around 4 kilos by then. And it is much safer to do a surgical intervention. So the youngest we have taken, 6 weeks.
Any limitations of anterior chamber depth because you need a manipulation there? So is there this thing that you should not be doing it when it's too shallow or?
Yeah, great points. A prior, you have to do an ASOCT and UBM. So those cases which have, other comorbidities, we don't include into, this study. So you may have to consider their keratoplasty.
Can you share your slide? You were supposed to show something, so.
I don't know. It's not allowing me. I don't know yet.
So.
Yeah, what was your other question? So how long do I wait? So what it's amblyopia is a time-bound phenomena. So I can't wait, beyond 6 months. If, this child, these are all developmental abnormalities. And it's a very, very important when it comes to amblyopia for 6 months. So you wait and watch for about, 6 to 8 weeks time. If you don't see an expected response, then you may have to consider alternative. Out of, this 34 eyes, only one child bilaterally, which had a nephroblastoma. So I have to send to, Mumbai Tata Memorial for a 1.5 nephrectomy. That child is doing well with a large sector iridectomy. Yeah, that's the only case where I would have, considered keratoplasty, but the systemic condition did not allow. Now child has become, 7-year-old. The cornea is also significantly grown, and the child has a 2800, pretty good ambulatory vision with the aphakic glasses. Yeah, so that's the one case perhaps I would have considered a keratoplasty. And with the newer surgical algorithm, we have 100% of the cases have improved. I don't know, I'm unable to, share my slides.
Okay, no problem.
You combine these cases with the iridectomies so that you have an earlier visual rehabilitation in these patients?
Correct. We have considered iridectomy, those cases which have
Now
a
we can
more than-
see. Now we can see the shared
Okay.
screen.
Yes, share screen.
Okay, yes,
Yeah.
more than 7 millimeters. See, yeah. So this
Yeah.
is a simple algorithm. If you look at here, the step 1 is a mild disease where you have a central 3 to 4 millimeter defect. And when you dilate, if you get a decent retinoscopy, you're able to see the retina clearly. You don't need to do anything. So either use a dilating drops in certain cases, optical correction, and intermittent patching. And naturally, this opacity resolve over a period of time. In a step 2, that is a moderate cases, irrespective we are dealing with a type 1 or a type 2 Peters, the opacity under 7 millimeter, my technique works extremely well in these cases. Those who have a defect between the 4 to 7 millimeter, provided your peripheral cornea is extremely clear. Whereas in a step 3, this is a severe cases, could be type 1 or a type 2, where opacity is more than 7 millimeter. So you have to do a iridectomy here. Okay, because it takes a long time, as I said, to 12 weeks or more for a resolution. And I can't wait, I can't run the risk of amblyopia. Now, this is a series where we do optical iridectomy. Okay, optical iridectomy essentially is not a physiologically correct. So it may have a more aberration, child may be photophobic, child may even lose a near vision. So the reason is, the near vision in a triad, you need to have a meiosis, convergence, and lens accommodation. Okay, so once you do a large sector iridectomy, they would lose a near vision. You may have to give a near addition as well in these children. So this is a simplistic algorithm. If we go by this algorithm, I'm sure we all can have 100% outcome. So less than 3 millimeter opacity, don't touch, just give an optical correction and observe them carefully. 2, yes, the ideal candidate of 4 to 7 millimeter. Those who are above 7, you have to combine with the optical iridectomy. How big should be iridectomy? It should be at least 1 quadrant or a 4 clock hours, or intraoperatively, one should clearly see a red glow. And through that, the island which we have created should be able to refract or visualize a fundus. So these are all the end points. These are very clear cut and very simplistic.
Oh. So is there any easy procedure for general ophthalmologists? Like this may not be feasible at all the centers. So any other modality of treatment for Peters anomaly?
Okay, general ophthalmologists without non-surgical, they can dilate. For a moderate defect also, they can actually use a dilating drops, do intermittent patching, and observe, naturally Peters anomaly tend to regress over a period of time because of a natural healing process. Secondly, cornea is continue to expand. Thereby, you will have a much bigger optic zone. So they may get benefit, Yeah, the care has to be taken. The moment, they have any signs of, preferential fixation, if they have nystagmus, if the child, lagging behind that, functional vision. So those are all, alarming signs are red flags where immediately you have to refer him or her to the pediatric cornea specialist.
Yeah. Dr. Murli, did you use any other modality of visual rehabilitation? So besides glasses, were these patients put on any lenses? Because
yes,
you do see an irregular astigmatism in these patients. So, and how early would you put these patients on lenses?
No intraocular lenses.
No, I mean to say the scleral lenses or the rigid gas permeable lenses.
Yeah, we tried, rigid gas permeable lenses. Some of these cases are on RGP, provided, if the parents agree and if they are able to capable of, handling those lenses. It's a bit tedious. I think, AFAK glasses, most of the type 2 abnormality, they did extremely well. Because type 2 abnormality, biggest problem is glaucoma is almost 70%. So all this, 7 cases which had a type 2 abnormality, minimum they have to be in 1 glaucoma medications. 3 had a trap and 2 had a tube also in these cases. So it's glaucoma risk is a very, very high in the long run.
So you mean to say that, because I saw in your results that one of the risk factor for the failure was glaucoma. So I presume these patients developed later on the glaucoma.
Correct.
So when they were selected, there was no glaucoma pre-existing. Yeah.
Correct. So the reason is that, they have something trabecular dysgenesis. This is anterior segment developmental abnormality. So both corneal endothelium and the trabecular meshwork derived from the first wave of the neural crest cells. So when you have endothelial abnormality, they're likely to have a trabecular endothelial abnormality as well. And they're likely to have a, higher risk of developing glaucoma.
And in this study, you have excluded the cases of glaucoma, but with your experience now, do you think we can definitely take up the patient, because you see a lot of patients having glaucoma in Peters anomaly? So can this procedure be done in the patients who have coexisting glaucoma at the outset?
No, if they have uncontrolled intraocular pressure, I don't recommend.
No, but if you can, okay, so you would first control it surgically or?
Correct. Yeah,
Yeah.
mostly they need a surgical. Yeah, it's like a primary congenital glaucoma. The moment you make a diagnosis, it's a surgical diagnosis.
Okay, so the
So you
first would
have-
be a glaucoma control and followed by your corneal management.
Correct.
Do we have any other questions? Nikhil, you have anything to comment, or what is your clinical experience? Because in private practice, how often do you see these patients, and do you really tend to manage them, or?
I used to manage, do pediatric in the beginning when I started practice and all that, but of late it is increasingly difficult to manage GA with very small children and the follow-up, and there is a lot of you personally feel upset when things fail. Like I've had done grafts in children, and when they fail after a few years, it hurts my mind, so I've stopped doing it. I try to send it to LVP, Dr. Murli, and because I think they need a lot of support system is required. Individual practice, that is very difficult. They need more of an institutional setup where everything can be done, and then of course, even if they do go to LVP or we need to keep seeing them so that locally here, we can take care of their follow-up and they are comfortable, because they can't keep going every time. So in between visits, maybe you can manage them locally also.
So
there is a question in the chat box which says that how to identify the abnormal endothelium which is to be removed.
Okay, yeah. So when you can actually stain and see, so you have kind of a stippling staining. You have iris, which is defective, maybe iris strands attaching the perimeter of the opacity. Okay, if you have seen that surgical video, so they're right behind where you have a corneal edema or opacification. Okay, and not only you have to scrape the area where you have a corneal excavation.
I think we have lost him.
5 millimeter into a healthy area, because you need to remove these abnormal cells in order to kickstart or facilitate normal endothelium in the peri-lesion, around the lesion. So in order to expand and try heal and resolve corneal edema, that's how it goes in a cycle. So how do you know there is endothelization? At this point in time, you don't have any diagnostic tools. OCT only tells you about, what modulation have happened at the corneal thickness, all that. Otherwise, at this point in time, I don't have any tie which recognize endothelization. It's basically a surrogate marker. You look at surrogate marker like a corneal edema, resolution, scar remodeling. These are all the endpoints we look at.
You go 1 millimeter beyond
Yes,
the opacity.
Correct. You have to go at least 0.5 to 1 millimeter beyond the opacity, so that you remove that even a transition zone. You have a healthy zone and abnormal zone. Even those cells in the transitional, we want to remove that.
Maybe some of these very children who you did very initially, if they're older enough, they might allow you to do a specular in the mid periphery
Yes,
or
sir.
something.
Yeah, extremely good question. We've done a good endothelial data. Now we have that paper is also ready to be published. We have 35 children, who cooperated, and since it's a 10-year data, we've done endothelium, sir. They have a good endothelium. 2800 is an average cells here, and they don't show any polymegathism, pleomorphism, what we typically see in a Fuchs. They're pretty good. Also, fact that up to 2 years, So endothelium retain the peripheral, mitotic capacity. Okay, although they are in a resting phase, up to 2 years, the stem cells which are located inside the Schwalbe's line, supposed to multiply and facilitate expansion. Therefore, we don't end up losing endothelium. So, for instance, if we do a keratoplasty, so the peripheral host endothelium spread onto the donor cornea. That's how donor cornea for a keratoconus non-endothelial disorder tend to do extremely well. So the similar analogy here. So great question, Dr. Nikhil. Yes, we have done that.
Murli, I have one last question. Is that so? I went through a lot of publications and I realized that there are some people who have done desmetorexis, and there is a group which is also calling a similar procedure as SER. So is it the same procedure or is it something which is different that we are looking at?
Yeah, so yeah, I think so one of the my guideline or suggestions to all clinicians who are pursuing research. So one of the mistake I made is when I had 18 cases, I let my secret out. So that led to one of the very big person from South Asia. He approached me. So I have all that email, track and evidences also. So apparently later I came to know from Ken Nischel that person had only one case. So this is after a leaked information. So he insisted I share my 18 cases. But Ken Nischel was a big support for me. He resolved that conflict. So we have a 10 years data, Parul. So this gentleman has published a single case that is in 2017, yeah, cornea. So yeah, so I don't know, so ultimately, the children should get benefit. We are not here to get the name or something. So yeah, so all young researchers or young ophthalmologists, so be vigilant, be cautious, guarded, protect, even if you have some good technique, and share only with the people whom you completely trust.
I think it was a wonderful presentation, sir. And it was a really good, as a clinician, we don't see too much of children and these cases. But I think this procedure is a very simple procedure. And probably we can definitely think of doing these cases in our clinical practice also. So thank you for this wonderful procedure.
Thank you.
So
I think, there are a couple of questions here. Dr. Sapna Kini, she has asked, can we do it in around 5 to 6 year old?
Okay.
Bilateral asymmetrical? Yes, madam, I've done even up to 7 years. But you have a dense amblyopia. Maybe the corneal opacity per se may regresses, but I'm doubtful about the functional vision. Yeah, it can be carefully considered in such a cases after explaining that, the child may not, have any functional improvement. It's only for a cosmetic, improvement. Right, sorry. Go ahead, Dr. Fisher.
Yeah, so I think we have
exceeded the
now
time.
exceeded the time, but I'm sorry for extremely sorry for the mess today, because we had a PG session going on, and then an IT people switched the things. So nevertheless, thank you so much for this elaborate discussion on this novel technique. It was great learning for all of us today who have been awake till 10:30 today, and it was worth it. Definitely. I thank you, Dr. Murlidhar, and I have Dr. Anaga Hirur.
Yeah.
Anaga, if you could.
Yes, I'll just give the mic. Yes.
Yeah.
Thank you so much, Dr. Murlidhar sir, for the excellent pearls. And it was absolutely a treat to watch all this. And lots of learning here. Thank you, Dr. Nikhil Gokhale, Dr. Parul, Dr. Shruti, Dr. Chaya ma'am. Thank you everyone, Dr. Shweta, for the lovely presentation also. Thank you, Dr. Vaishal, for all this. And thank you for everybody for being here. And lovely, sir, Murlidhar sir, it's absolutely hats off to you for such an innovative technique. Thanks, sir. Thanks a lot.
Thank you, ma'am.
A special thanks to Dr. Chaya ma'am. I think we missed
Chaya
her.
ma'am, yes, absolutely.
Yes.
Thank you so much.
So I thank the Entod people also.
Yes, and Todd also, thank you very much.
Yeah.
On behalf of MOS, sir, thanks everyone, and thank you, sir. Especially thanks from us.
Thank you. Thank you so much.
Thank
Good
you.
night, sir. Good night.
Thank
Take
you.
care.
Thank you, Dr. Murli.
Bye.
Bye. Good night.
Thank you.
Thank you.